As this is an older dog, the incision is just behind the umbilicus. The fat is trimmed away rather than blunt dissected. This prevents the subcutaneous fat getting caught in the ovarian clamp, gives better exposure of the linea alba, clearly separates the fat and skin when closing. Lift the muscle high, for the stab incision, and keep the blade holder parallel to the dog. Odds on there is a big fat spleen below. This dog just wants to bleed from everywhere. To extend the incision, raise the muscle with adson forceps, and ideally use Mayo scissors to extend the muscle incision. Some people will insert forceps to raise the muscle, but the muscle cut falls short. Others use the forceps and reverse blade. You only consider this when more experienced. You can tell when you are cutting the linea alba, as it's much more tougher. Initially, everyone finds it hard at the start to find the uterus. Both horns run parallel to the vertebrae. In young dogs, the uterus is very small, low down and usually close to the vertebrae. In older dogs, it is larger and tends to be higher up. Run your index finger down the abdominal wall. With the contents behind your finger, touch the vertebrae and then start sliding up the abdominal wall. With your finger hooked, make sure the intestines are behind your finger. Intestines are flatter. Whereas the uterus is more tubular, the more uteruses you feel, the better you will get. If any abdominal fat pops out, or anything non-uterine, return it. If you are unsure whether it is the uterus, check for an ovary or bifurcation. To grasp the ovary, hold the uterus in your right hand. With some tension, but not too much, then push down on the body wall with your left hand. Once you have it, transfer the ovary to your right hand. Once in your right hand, pull on the ovary. Don't worry, the suspensory and renal ligaments are protecting the ovarian vessels. The uterus is more likely to break than the ovary, so never pull the ovary up by pulling hard on the uterus. Push down like shown. Keep some tension on the ovary. And then with your left index slide down the suspensory, push down at the insertion to the rib, or as close to it as possible. The more cranial your finger, the further you are from the dangerous vessels. Don't use the twing-twang technique, as this can be dangerous. Do not break the renal ligament. We want this to protect the vessels. The renal ligament runs straight to the kidney, whereas the suspensory runs round the back of the kidney. In no time you will be able to break this ligament in seconds, greatly increasing ovarian exposure. We need now to make a window in the broad ligament, identify the ovarian vessels and go clearly to the other side. Away from them, you need a clear, translucent, non-vascular area. Place the ovarian clamp, preferably a Carmalt clamp, below the ovary. Don't push down hard. Walk the clamp down, while your other hand holds the ovary up. Hold the clamp together and remove any fat or skin etc. getting caught. Once in position, click once or twice. This will initially feel very strange. Place 2 clamps the other side of the ovary and cut between. This separation of the uterus is safe. It gives you excellent exposure of the ovary, and makes the ligature placement and positioning far easier. I have probably used this technique on 15,000 bitch spays. I suddenly seem to be getting far more blood than I should. I have made a stupid mistake. I have not placed the clamp through the window I made. The clamp is too close to the vessels and I have damaged one of them. I need to reclamp quickly and see if I can get it below the bleeding vessel. This is a common error for new graduates. My main objective is to stop the bleeding by placing the ligatures lower. You can see how this vessel has ripped open. I have managed to get the clamp below the damaged vessel, so the bleeding has stopped. Usually the vessels aren't this fragile, especially in younger dogs. So I place my first millers. Their advantages over surgeons is that they don't bounce back. With a surgeon's it will tighten, but as you go to get the next throw on, it loosens. Once you have tightened the millers, it stays tightened. Some call them strangulating. The other advantage is that you can form them and then push them down deeper. What I am trying to do now is rotate the clamp. This helps me to keep the knot low when I tighten it. I usually put a pair of curved forceps through the handle. So now we raise the ovarian clamp to make room for the next millers. Regards the crush bed, it doesn't matter if you use it for the next millers or not, as position of the ligature is more important. Make sure you are 100% sure you are clearing the ovary. I need to trim the tails of the last millers really short, otherwise they will be caught in the next millers, compromising the effectiveness of the ligature. Okay. So now we have placed 2 Miller's knots, which is usually more than sufficient. One main advantage of this technique is that we can check for bleeding in a very safe way. We take both clamps off and check. The ovarian artery is under high pressure, and if the knots were poor, they tend to spurt. For sure there is no serious bleeding, but there may be a slight ooze. I take no chances and reapply the clamp to add another ligature. But you can see how less stressful that is, compared to cutting off the ovary and have a loose hold of the pedicle, which you want to reclamp. Quite often they slip out of the forceps and then you have to widen your incision and go deep down to the kidney area to reclamp. When ligatures snap, it can be dangerous. It can rip ovarian pedicles or testicular vessels completely off. In this case, no damage was done. To eliminate possible damage, always work close in. Don't hold the suture material a long distance from the knot, otherwise the force of the tug from the snap will be stronger and more destructive. When a Miller's snaps, it nearly always keeps its compression, so I place a surgeon's alongside the Miller's. But with the knot on the opposite side, this way the tightness, compression, and ligation of the Miller's is preserved by the surgeon's knot. Now we remove the ovary with a blade. I use a blade so the cut is flush to the clamp. Snip the tails. And as we have already checked for bleeding, release the clamp. I have seen new graduates trying to hold onto the pedicle after the clamp is removed, and they have damaged what's left of the pedicle, so much so, it has resulted in the last Miller's knot being compromised and times have fallen off. Next we are going to tie off the broad ligament to reduce the amount of fat present when we ligate the uterus, to help exteriorize the other side of the uterus. Most vets just tear them, but I prefer to ligate and have no blood, rather than oozing from the broad ligament, and sometimes they are quite vascular. As shown, keep the uterine vessel with the uterus. And on the other side to it, make a window in a translucent area, where you are 100% sure there are no vessels. If the broad ligament is large, tie off with a Miller's. If it is small, use a surgeon's. We now repeat everything for the other side. To grasp the ovary, push down on the body wall with your left hand, then switch the ovary to your right hand. And while holding it under tension, slide your left index finger down the suspensory to the insertion to the rib, or as close it as you can. Remember, the more cranial you are, the safer it is. For this side, the suspensory is always thicker, so can take up to 60 seconds to break. First, make sure you are on the suspensory. As you go down, you should feel it go around the back of the kidney. If it goes straight to the kidney, this is the renal one, don't break it. We need this to protect our vessels. To break the suspensory, first try a downward force. If this doesn't work, then apply force laterally, and try to break it in two. And if finally these don't work, from the lateral side, slide your finger just underneath and push upwards. Every one of us have heard a horror story of breaking suspensories. Don't let this put you off. If you use this technique, you will stay safe. One of my friends ripped off the ovarian artery and sadly the dog bled out and died in 20 minutes. His technique was to strum the suspensory, high up, close to where the vessels are. You must always break the ligament at the base or as close to it you can get, and never try nicking it with scissors. So now make your window in the broad ligament, away from the vessels. Far down. And in a translucent area. Slowly walk down the Carmalt clamp. Removing any fat or skin caught, hold the ovary while you walk it down, then click the clamp, once or twice. Separate the uterus, by placing 2 clamps and cutting between. While holding the ovary, raise the Carmalt clamp. The second Miller's doesn't have to go in the crush bed, but helps if it does. Form the second Miller's, nudge down away from the clamp, and then tighten. Following with 5 to 6 ones. See how rotation of the clamp helps to keep the knot down at the cranial aspect. Now remove both clamps and check for bleeding. This is the safest way of checking. Rather than after you have removed the ovary and have only a small amount of tissue to hold onto. There might be a slight ooze, so I replace the clamp, ensuring I have cleared the ovary, and add another ligature. The finger is pointing to the uterine vessels. We need to stay clear from. So we make our window in the translucent area. Through the window, double clamp and cut between. Select surgeons versus millers on the size of the broad ligament. Sometimes I just place the one clamp near the body and leave the second. The idea of this is to see how vascular the broad ligament is by looking how much blood is coming out from the unclamped side. We don't want to pull too hard on the uterus, or else could damage the uterine vessels at the base. I have had dogs in the past, where millers have cut right through the uterus. This is why I start with the surgeons. I also used to use crush beds, but had some dogs where the uterus fell to pieces with the clamp, hence I don't use crush beds. The worst dogs for fragile uterus and ovaries tend to be older, slightly fatter, and have had several litters of puppies. So after the surgeons we place a millers, if I think the uterus is really fragile. I would choose a larger suture like 4 metric USP1. As you know, a surgeon's knot is 1 loop, whereas a miller's is 2 loops. It is important to make sure the loops lie next to each other, and not separated, as indicated by the pointers. The next ligature is a transfixing, one you may not have seen before. We pass a needle through the center of the uterine body, but the needle is in the center of the suture material. Once through the uterus, check both strands are equal and then cut out the needle. We are then left with 2 strands, 1 for each side of the uterus. These ligatures focus on the uterine vessels. Once I have worked out which strand pairs up to the other, I usually clamp one side, so not to get them mixed up. When we tie the surgeons, as soon as we let go to make the first loop, the knot bounces back and loosens up. It is important to ensure the first one throw is super tight, as this will retighten the surgeon's knot. With transfixing ligatures, make sure to leave about 1 centimeter before the cut. If you use a clamp, don't leave the crushed tissue on the dog's side. The Danish are very strict over this. Check for bleeding in the position it is now, then nudge into the abdomen and check again for bleeding. The reason for this is that, when bent over the muscle, the vessels are trapped, and a possible bleeder may be trapped and not bleeding, but then start when no longer trapped over the muscle. I sometimes close with a simple continuous pattern. A simple interrupted or cruciates. With simple interrupted, I place one at the top and then one at the bottom. The reason for this is that sometimes the muscle cut will underrun the skin, so it is easier to place them now and not struggle at the end. With this dog, I use simple uninterrupted at the top and bottom, then cruciates in between. When you have been slightly off target, I usually pick up the peritoneum when closing the muscle. Advice on whether to do this seems to change every few years. When we start the fat layer, it is important to hide any knots, so we go deep superficial one side, and a mirror image on the other, which will be superficial deep. The first pass of the needle needs to be deep superficial. Otherwise the knot will be pulled up. We continue the fat with a simple interrupted pattern. Finish the layer with an Aberdeen or surgeon's. I prefer the surgeon's, as you can control tension, and the knot is more secure, as well as being a better anchor for the skin. Normally we would keep the long tail and go straight into intradermals. I wanted to show you an alternative to intradermals. They are basally intradermal mattress sutures. Take an intradermal bite of one side and then the same on the other side, and then tie off with a surgeon's knot. Try and keep the entry point and exit point in the same position on both sides. It is harder to make the wound look neat, but one advantage is the wound is less likely to break down, and as the knot is composed of 2 strands and not the 3, they are easier to bury.